Hello, my name is Christina Connel. I am the clinical pharmacist at the Ryan Wyatt OSU Internal Medicine Specialty Clinic. I specialize in HIV, so today I am going to go over the use of Lopinavir and Ritonavir and other antiretroviral therapies for the pharmacotherapy review of SARS-CoV-2. This lecture is an update of my April lecture on the same topic, and its information is up to date as of the date of recording, which is today, the 30th of June. As in my previous lecture, we're going to go over the proposed mechanism of action for Lopinavir, Ritonavir, and other protease inhibitors in the use of SARS-CoV-2. We're going to talk about what other drugs there are besides Lopinavir. We'll go over the Lotus China trial, which was our first really randomized trial for this drug, and then go into what are some ongoing clinical trials and what we can look for, as well as the adverse effects, and then kind of a summary and current recommendations for the use of HIV medications for COVID-19 disease. So the mechanism of action, on the right-hand side here, you can see the HIV life cycle. And so Lopinavir and the other protease inhibitor that we're going to talk about today, Ritonavir, does have activity against HIV as it cleaves the precursor of polypeptides. This is an essential role for HIV replication. And so the fact that these protease inhibitors can inhibit that step stop the replication of HIV. So Lopinavir and Ritonavir was developed as an HIV protease inhibitor, but in vitro it does have activity against SARS, the non-structural protein 3CL Pro. So the proposed mechanism for SARS-CoV-2 is that it inhibits at this C3L1 Pro protease. So coronaviruses encode for a different enzymatic class of protease, so they within the cysteine protease, and theoretical evidence exists that Lopinavir Ritonavir will inhibit CL1 Pro protease. This has been shown effective in vitro model studies of both SARS and MERS. However, we'll talk about some of the clinical evidence here in a little bit later. So let's just talk about protease inhibitors in general. So Lopinavir and Ritonavir, which will be abbreviated throughout the rest of this lecture as LPV/R, just for the shortening of sake, is brand name Kaletra. Kaletra was FDA approved in the year 2000 for HIV treatment. And then Ritonavir is also a protease inhibitor, but it is used as a CYP3A4 inhibitor to help the kinetic effects of Lopinavir and also Ritonavir work better. So if you look at the graph on the right-hand side, you can see Lopinavir, when it's used alone, that purple line, Lopinavir only lasts in the system for less than 12 hours. And so it would require Lopinavir by itself to be dosed multiple times a day. However, you add Ritonavir on as an inhibitor, you're going to see decreased metabolism of Lopinavir and therefore increased levels. And what you see is a nice smooth area under the curve that actually lasts more than 24 hours. Ritonavir, which is another protease inhibitor that was FDA approved for the treatment of HIV in 2006, has a similar kinetic curve and also needs pharmacokinetic boosting. And so Ritonavir can be quote unquote boosted with Ritonavir, but it also can be boosted with another pharmacokinetic enhancer, cobicistat. And so Ritonavir and cobicistat were co-formulated in 2015 into the brand name Prescobix. And so you will see reference throughout the slide. I will refer to the generic name of Ritonavir, but just know that there are a couple different boosting agents that will help. And when we get to drug interactions, we'll talk about why that's important. So what is our current evidence for Lopinavir and Ritonavir? There is some in vitro evidence that Lopinavir and Ritonavir has activity against SARS-CoV-1 and MERS-CoV. So there is some conflicting evidence though. So a 2013 study showed that there was no activity against MERS. However, in 2014, another study showed inhibition of MERS replication, and that would be the DeWild study from 2014. The CHOO study in 2004, which predates those other studies that I mentioned, showed activity against SARS, but it was when it was combined with ribavirin. And so we have in vitro evidence that suggests that there is benefit when combined with ribavirin. So there was quite a bit of observational data looking at Lopinavir in COVID-19. However, the first randomized trial that we got was the Lotus China trial that observed patients randomized between Lopinavir, Ritonavir, and standard of care between the dates of January 18th, 2020 and February 3rd, 2020. This was a group of just under 200 patients. 99 of them were put into the Lopinavir Ritonavir group, and 100 of them were put into the standard care therapy for 14 days. Standard of care was defined as the use of as-needed supplemental oxygen, ventilation, antibiotics, renal replacement therapy, and ECMO. And the primary endpoint that they were looking at was improvement of 2 points on a 7-point ordinal scale of clinical improvement, or live discharge from the hospital, whichever happened first. So when you look at the results of this trial, there was actually no difference in clinical improvement, which was their primary endpoint. Both arms, the Lopinavir group and the standard of care arm, had improvement at about 16 days in both groups, so no difference. There was also no statistical difference in the secondary endpoints. However, you did see some numerical differences in a couple of points. So the 28-day mortality was lower in the Lopinavir Ritonavir arm, 19.2% versus 25%. And the numerical difference in the ICU stays was also lower in the Lopinavir Ritonavir arm, 6 days versus 11 days. Again, these did not hit statistical significance, but there was a numerical difference that is just interesting to note. There's also no difference in viral RNA loads over the time of the study. I think there are a couple of things of significance to note here for consideration. 14% of the entire patient population on Lopinavir Ritonavir were unable to complete their 14 days because of GI adverse effects. GI adverse effects are a well-known adverse effect of Lopinavir Ritonavir, and so that was actually a limitation because so many patients were not able to complete their course of therapy. The other thing to think about is that the Lopinavir Ritonavir arm was given monotherapy. There was no additional agents given, which is interesting because the 2004 CHOO study that I cited earlier did show evidence in SARS-CoV-1, but that study was also in combination with ribavirin. And so it does leave the question, if you added ribavirin or a different agent, would that be beneficial? The other thing to note for this study is that patients were randomized on an average of 13 days. The interquartile range was 11 to 16 days, and so these were patients already in fairly progressive disease of COVID-19. The window of benefit for Lopinavir Ritonavir use may have actually closed at this point because, again, that CHOO study showed early therapy benefit, but not as rescue therapy. In this study, even though it was small, there was an accelerated recovery in patients that did start treatment prior to day 12. But if they started treatment after day 12, there was no difference. And so those are just some things to think about. Additional agents, if they had been added, would it have been beneficial? And then if this had been as initial therapy instead of rescue, would it have been beneficial? And so what kind of trials are ongoing? If you look at clinicaltrials.gov, there are currently 77 trials as of today ongoing that will use Lopinavir Ritonavir in some fashion in one of the arms. But the trial I want to mention here is the Solidarity trial that is a worldwide trial by the World Health Organization. As of June 3rd, there were 3,500 patients enrolled in 35 countries, and this trial will look at Remdesivir versus Lopinavir Ritonavir versus Lopinavir Ritonavir plus interferon. And so a very large trial that hopefully will show us some difference between a couple of different treatment modalities. For Ritonavir Ritonavir, there isn't a lot of data there, again, because it has a mechanistic similarity to Lopinavir Ritonavir. There's been some interest in shown in it, not as much in vitro data. but there are currently 9 trials for Ritonavir, Ritonavir plus COVID listed on clinicaltrials.gov. And so we'll have to see, again, no real in vitro data suggesting it. So that would suggest that we won't have clinical data that will support Ritonavir use in COVID-19. But again, we will await these trials. And all of these trials are currently recruiting or not yet recruiting. And so we do not have clinical data as of yet. So talking about the adverse effects of both Lopinavir, Ritonavir, and Ritonavir, these are HIV protease inhibitors, which we know have a vast number of adverse effects. And so remember that 14% of patients in the Lotus China trial that we have data from could not complete their 14-day course because of adverse effects that were GI related. These were primarily anorexia, nausea, abdominal discomfort, and diarrhea. This matches with what we know from our HIV population. GI upset is very common among protease inhibitors. You can also see rash, QT prolongation, which can be problematic when it's combined with other QT prolonging drugs. And then I think metabolic effects long-term, we've seen hypertriglyceridemia and hypercholesterolemia in our HIV population. Now, will that be a major effect in a 14-day course for COVID-19? Maybe, maybe not, but it is something to think about. We've also seen hepatic effects with increased ALT and AST. And then worth noting here is also the drug interactions that are due to CYP3A inhibition. So CYP3A is a common metabolic pathway for many of our commonly used drugs, and so you have to think about that when you're using either Lopinavir, Ritonavir, or Ritonavir, Ritonavir. Common drugs to think about through this pathway are going to be statins, steroids, calcium channel blockers, opiates, as well as the DOACs. And so there can be some pretty significant drug interactions in there. And so you just need to be aware that those can be problematic because so many of our patients are on these commonly used drugs. So to summarize, for the use of Lopinavir, Ritonavir, and Ritonavir, we still need more data. There is no current recommendation to use either of these drugs outside of a clinical trial. However, I will note that if it is going to be used, the current dose recommended is the HIV treatment dose of Lopinavir, Ritonavir, 400, 100. So that's 400 milligrams of Lopinavir with 100 milligrams of Ritonavir twice a day. This was the dose that was used in the Lotus trial and is currently the dose that, if it is going to be used, is recommended. But again, neither of these agents is currently recommended outside the use of a clinical trial. And so we will continue to await data, especially data from the Solidarity trial. If you have any questions, please do not hesitate to contact me. Thank you very much.